Well, thanks, Paul, very much. You've already seen two different slides of the High Value Healthcare Collaborative, and they tried to identify Baylor, Scott, and White. They haven't got the geography, they got the state right, but they didn't get the location right. So Scott and White Healthcare has been around for 117 years. It's in the central portion of the state. Our system, our footprint is 30,000 square miles, so it's the same as New England. Last October, we merged with Baylor Healthcare, which is in Dallas, and that's 107 years old. So as an institution, we're relatively young. And so what I'm going to do is share you a little bit of our history aligning research with institutional goals from a north perspective and a central perspective. So that would be the legacy Baylor healthcare system in the north, and the legacy Scott and White system in the central area. And as a team-based care, none of this would be able to be possible without input from the folks up here. Dr. David Ballard actually happens to be here today and part of this, so any questions can be dealing with that. So the way that we look at governance and the way that we look at our structure is really kind of a circle of care. Nothing happens without finance, and of course we all know no margin, no mission. So the key of creating a financing arm that's going to be able to align is also having the right people on the bus. That's no difference, but it's also where our education and research comes in, to embed that as part of our culture. And so even though this goal is talking about aligning care and research, I think even though it hasn't been declared yet, education has to be part of that. If we're going to have the new cadre of people delivering care, understanding how culture is and quality is part of a driver to improve care all the time. One of the things that our northern colleagues invested in was a STEEP Quality Institute that Dr. Ballard chairs. STEEP stands for the Institute of Medicine Goals, so care that's safe and timely and effective and equitable and efficient and patient-centered. And then lastly, the servant's excellence. So this is where our patient models come in. So another way of looking at this circle of care, it drives our mission. And so the mission, if you look on the bottom, talks about how lean thinking supports everything that we do. So it's not more is better, it's the right care, the right time to the right person. And so the mission embeds that personalized care, but it also looks at research and improvement as a part of that culture. So if you look at that, then there's a circle of innovation that's kind of outside. So that innovation is how do we scale things up? I mean, we are a $2 billion Scott and White entity that's merged with a $6 billion Baylor entity to create the largest nonprofit healthcare system in Texas. So how do we make this thing work as we also continued our integration? We've had a health plan at Scott and White for 35 years. We're part of the HMO research network. We've been dealing with population health in that model from a capitated payment model, but now how do you push that through a model with a Baylor Scott and White Quality Alliance where the 700 employed doctors in the Northern Division are linked with 2,500 independent doctors that have paid $1,500 apiece to join this Quality Alliance to share data and to move it into a different system. And how are those new care delivery going to work in this system? In other words, we're trying to design a system is the same way of trying to do a open heart valve replacement with the heart not on bypass. Because if we slip up and we have a oops data problem, that has a huge impact in our ability to make things happen. And then lastly, the population health. How are we linking everything together? This is the model that our governing board looks at, and so when they hold people accountable and where we want to go, obviously we're like everyone, everybody wants to be in the top three. I've asked, okay, who are the other two? And no one's given me the answer yet. So the strategy map, I'm just going to pop through this real quick. So when you take a look at the circle of care and the circle of innovation, it's aligning these different models in a way to say, how do we engage our community? How do we engage our process, our capabilities, and our finance? Okay, that's great. Those are strategic maps. Those are kind of things that governance kind of deals with. At the end of the day, how do you operationalize it? And the way that you do that is to make sure that in the Board of Trustees on a quarterly, at their quarterly meetings, this is part of what the report is. What are we doing on quality? What are you doing on research? What are you doing on these different markers? A leadership council compared of the people that are involved with this from an operational council that meets weekly, and that's where the chief academic officer sits as a peer, providing the input. And then the leadership, the clinical leadership council being involved, that's where nursing has a very important role to play. So I'm not going to go through this in detail, but what I wanted to highlight in the organizational structure that David works with as the chief quality officer for our system, clinical effectiveness reports to him, the patient experience reports to him, the officer for population health and equity, informatics, and then if you go into a more detail, the analytics and measurement reports under David, and then David then has the direct relationship with the finance as well as the business services and contracts. It's very important if you're going out there and contracting for services to manage populations and you're doing all this population health, if you're not getting paid for it because you haven't written it into a contract, you're giving away all the good stuff that you're doing, and you then at the end of the day everybody's wondering where's the money, and then it becomes problematic, as we know in most of our systems. So when you take a look at some examples as we look at operational goals to reduce mortality and morbidity, improve the patient care experience, manage health at a population level, and improve operating margins, these embedded areas are specific research programs that have been implemented to try and answer those goals. People make this thing work. And I think one of the things we heard in another aspect that Susan brought up, she wears multiple hats. I happen to chair our system ethics committee because I have an endowed chair in medical humanities. So when you talk about how do you make sure ethics happens, well, you know, you get the right people on the bus that are going to be able to move back and forth between these different models of trying to say, okay, how do we keep us aligned as things are popping up, and to be able to deal with that. And so as one, not to go into great detail, but just to show you the breadth of research as one is trying to meet those operational goals, as similar to what Brent had indicated. If you got somebody that wants to do a great research project, but it doesn't fit into anything, then yeah, you bring in an NIH grant, and the last I heard, it costs you a lot of money to be able to get, not only to get the grant, but then to implement the darn grant, which takes people away from other things. So when you take a look at the 4 lessons learned from our Northern Division, clearly there's a business imperative, but you got to have the governance and the operations aligned to shorten that cycle time and to be able to continue to show how this works and to do what you want. Federal funding is important, but sustainability, it has to be your internal operations that makes this thing work. And that when you have this as a day-to-day part of your culture, you'll be able to support that sort of quality research and then produce the outcome. Now I'm going to shift to the academic alignment at Baylor Scott and White Central, because this, I think, is how we are trying to say, okay, the IOM has come out with a lot of reports, Joint Commission came out with reports, where are we going to get this new workforce? How are we going to educate them? Oh, I know, we'll do a module that they'll kind of learn it for 1 hour, a self-directed online module, and then they can check the box they've had system-based practice and practice-based learning as part of their medical education or nursing education. And what we have tried to do is embed all of these research projects that's ongoing for improvement of delivery and having residents engaged in every one of them and having them involved with that. Having the didactic training so that they get through their minimum of 3 years, maximum of search. We have research days where health services delivery research has the same weight as basic science research, and that's an important message. It also gives them then the experience. When they finish their training, they're ready to go into a system, and they don't have to then get trained how to work in a healthcare delivery system that's under financial aspects. And so an example that we use, our traumatic brain injury, we take our PhD scientists that are looking at blood-brain barrier issues with the clinicians, looking at biomarkers for traumatic brain injury, and then with clinicians looking at the quality, with the quality investigators to look at how do you improve quality of care and life in these folks. Because, oh, by the way, in the state of Texas, we've got a mandate to cover traumatic brain injury post-care. And so the question is it better to cover these people with somebody in the home, to put them in a nursing home, to use a inpatient, rehab unit? Again, putting all those components together so you've got the alignment. So we think that a model that can work is to have the clinicians working day to day with the researchers, and our researchers, some are partners of our academic areas, some are employed clinicians. The academic operations helps to support. I mean, who pays for the statistician? If you want to does that come out of QI? Does that come out of, who pays for it? Well, these folks need a salary and they got to be able to deal with it. So what are the lessons that we've learned? Partnerships are hard. They're really, really hard because they rely on the personalities of the person who's in charge at that time. The High Value Healthcare Collaboratives, as an example, has been able to be successful because of the personalities of leaders willing to share amongst others, and others want to deal with that. From an academic standpoint, this issue of tenure track, non-tenure track, faculty titles that are modified, are you a professor or a clinical professor? What do you deal with? These can be major stumbling blocks and be distractions, especially when the academic center doesn't run a clinical enterprise, but expects the clinical enterprise to teach the medical students and or the residents. The grants, who controls the money? Do you flow it through the academic center that then takes its cut and then leaves less, which means the clinical enterprise has to fund more of the ability to deal with that? And then the last thing I'll just observe, as the LCME has required our medical schools and the ACGME has required our residency programs to do more things requiring more clinicians, the problem is the clinicians right now with meaningful use, electronic medical records, patient satisfaction scores, the day-to-day management, and oh, by the way, they usually have families that they're trying to be, happy with and everything else. There is a crisis in caregiving that no one seems to be talking about. It's patient satisfaction. What about the caregiver satisfaction? We talk about nursing burnout. We've identified that. But physician burnout, I think, is going to be an ongoing crisis as more of us baby boomers are thinking about retiring. God, hope the stock market stays up. If we ever retire, what's coming behind us, we're not sure if they're going to put up with some of the stuff that the current folks are. And so I'll leave at that point and turn it over to you, Mary.